Okay, today we're going to start with chapter 26, bipolar disorders. So the general description of a bipolar disorder is characterized by significant mood swings that include emotional highs like mania and hypomania and lows such as depression. Bipolar disorder is also known as manic depression, and it causes clear shifts in a person's mood, their energy level, their activity levels, and their levels of concentration. It can lead to intense emotional states that affect a person's ability to function, and it's a serious mental health condition that requires proper diagnosis and treatment. So, as you can see, the individual will experience extremes of mood polarity. So, it could be euphoric versus depression. Depressive episode is not required for a diagnosis. However, the manic episode is required for a diagnosis, and it is the most expensive mental health disorder to treat. So, the manic episode is when the mood is elevated for at least 1 week, and it must have any three of the following: inflated self esteem or grandiosity, decreased need for sleep, being very talkative, have racing thoughts or flight of ideas, having distractibility. They can have increased goal-directed activity or agitation, and excessive involvement in pleasurable activities. They'll also have mood disturbances causing social, work, or interpersonal problems. The hypomanic episode is impairment is less severe than the manic episode, and the length of the episode is at least 4 days. It's not severe enough to warrant a hospitalization, and they can have persistent, elevated, expansive, or irritable mood. Plus, it needs to have three of the following: increased self-esteem or grandiosity, decreased need for sleep, being talkative, having racing thoughts or distractibility, or increased goal-directed activity or pleasurable activity with high potential for negative consequences. So I'll give you a moment to read this case study about Deborah. So just to summarize some things about Deborah, she's experienced a manic episode. She's experiencing the inability to slow down or sit down or be comfortable in one spot. She's constantly moving. She's laughing in a hysterical manner. Her associations are rapid and she's unable to stay on one topic at a time. She has pressured speech. She's irritable but can escalate to angry remarks if the nurse asks for clarification. She makes sexual overtures to male patients on the unit, and she has not eaten enough nutrition nor has drank sufficient fluid, and she's slightly dehydrated. She has not slept for 3 days before her hospitalization. So if you could just read this following question, and we'll talk about the answer. So the correct answer is A. It's a manic episode. So unlike hypomania, the episode is serious enough that she has been admitted to the psychiatric inpatient unit. She can hardly stand in one place and is hysterical. She has rapid associations, frequently changing topics mid-sentence. Her speech is pressured and then irritable when asked to clarify. She has made inappropriate sexual overtures, and she's not eaten properly for 2 days and did not sleep for 3 days prior to the hospitalization. So when we talk about the depressive episode, it has atypical symptoms. They'll have hypersomnia and daytime sleepiness. They'll have hyperphagia, weight gain, craving for carbohydrates, leaden paralysis, paranoid thoughts or hallucinations, and irritability. Also, the bipolar depression is more disabling than the manic or hypomanic episode. The first symptom is in over 50% of the patients with bipolar disorder and lasts longer. Bipolar depression differs from unipolar depression or major depression as it usually is more debilitating and usually develops at a younger age than major depression with more paranoia, irritability, and hallucinations. So the DSM-5 categorizes bipolar disorder into 4 different categories. You could be bipolar 1, bipolar 2, psychothematic, or finally substance or medication-induced bipolar disorder. So when we talk about bipolar 1 disorder, the mood swings between manic episodes and major depression occur. There'll be rapid cycling of mood episodes in the previous year. They'll have melancholic features, psychotic features, or appear anxious and distressed. With bipolar 2, it's similar to bipolar 1, but the exception to bipolar 2 is that there's no manic episode, but at least one hypomanic episode lasting at least 4 days, and the major depression is lasting at least 2 weeks. With the cyclothymatic disorder, they'll have numerous mood swings between a hypomanic episode and a dysthymia episode, which is persistent depressive disorder, and it's continuously long-term form of depression. The swings either way are not as severe as mania or major depression, and the symptoms have occurred for at least 2 years without symptoms of remission for more than 2 months. So some objective behaviors that they'll experience is disturbed speech patterns, disturbance of social, interpersonal, or occupational relationships. They'll have disturbance in their appearance and in their activity, and they may have violent behavior, be divorced, have abusive behavior, experience job loss, or academic failure. With their disturbed speech patterns, they can have rapid speech or pressured speech, loud speech, or be easily distracted and have flight of ideas. Regarding their altered relationships, they'll experience failed relationships, job loss or job failure. They'll experience overbearing behavior. They can have an increased sex drive, and they'll alienate from their family. And some things that cause the relationship problems is the manipulation of others' self-esteem, their ability to find vulnerability in others, their ability to shift responsibility, limit testing, and again, alienation of family. Some trends among individuals bipolar disorder, they'll have failed relationships. They may have difficulties maintaining long-term friendships. They'll experience job loss or job change. They have a need to engage people even if they are strangers. There can be overbearing and intrusive in conversations that alienate others. They have mood lability leading to falling in and out of love rapidly. So now I'll give you a second to read on about Deborah. So as you can see, she's laughing and talking rapidly and having pressured speech. She runs from one unit to the other. She abruptly interacts with staff and patients and sometimes violates personal space. So there's some classic characteristics. So now we'll talk about psychotherapeutic management. So the goals for treatment would be getting the acute mania under control. You want to prevent the relapse when they are in remission. You want to return them to their prior level of functioning socially, occupationally, and interpersonally. So what intervention do you predict is the most appropriate for her behavior? So seclusion and restraints are definitely not the answer. Pacing with the patient may be helpful, but only after she receives the PRN medication. So the answer would be A, you want to offer the PRN medication. When we talk about the nurse-patient relationship, what you want to do is you want to be matter of fact. You want to be clear, concise with your directions or your comments. You would allow the pacing as it's appropriate, but you do want to set limits. So, which is the appropriate intervention here? So, the answer would be D. You want to provide frequent, nutritious, portable food items. Some nutritional interventions would be, again, providing the portable food snacks and drinks for patients who cannot sit still. You want to provide high protein, calorie snacks, provide daily multivitamins, and weigh the patient regularly. Regarding the client's sleep, you want to provide a quiet environment to promote sleep. You want to structure activity to avoid stimulating activities during the evening. You would want to reduce caffeine intake, especially in the evening. And you want to assess their sleep rest patterns. When we talk about medications, the most used medication in bipolar disorders would be lithium and other mood stabilizers. Sometimes they use anticonvulsants such as Depakote or some atypical antipsychotics. When we talk about milieu management, safety, again, is always your top priority. As best as you can, you want to provide staff consistency. You want to reduce simulation in their environment. You want to have a calm therapeutic approach when they're escalating. You want to reinforce appropriate behaviors um, in hygiene and dressing. You want to promote good nutrition and sleep issues and establish routines. You also want to reinforce hygiene as an appropriate attire to avoid ridicule and embarrassment. You want to engage them in achievable activities that increase their self esteem. You want to promote establish milieu routines to avoid anxiety and confusion and offer medications as needed. Some patient education. You want to teach the patient and their family about bipolar illness and management. So you want to talk to them about how they would identify symptoms of a relapse, side effects of and therapeutic effects of medications, some coping strategies, um, community support systems in the community for bipolars, and how to seek emergency treatment if the symptoms are out of control.